So good morning, everyone. Firstly, it's a real pleasure to welcome all of you to this teaching webinar presented by the Department of Neurosurgery at the University of Pretoria. I'd like to start off by thanking firstly BK Medical, Sonoclear, the University of Pretoria for their support of this teaching endeavor. And then a special thanks to the team from EOA, that's Gugu, Yoshni, and Claire for making this quite a seamless undertaking. So I've got to mention very quickly that, and at trying an uncertain time as this is, I must thank all of you for making the time and effort to attend this webinar. I've got to welcome our esteemed speakers, and I think given the sort of presence that they have internationally, I'll introduce each one of them individually. And then just a brief overview, and I'm going to set the tone for the meeting by keeping quite strictly to the 5 minutes I've allotted to myself. The use of intraoperative ultrasound, specifically in brain tumor surgery, something all the speakers in this forum have tremendous experience with, and as a result, they advocate quite strongly given the clear benefits, most of which will be highlighted during this session. So we, as a team, the faculty of this meeting, had originally planned a hands-on workshop. But given the current set of circumstances the world finds itself in, we agreed to present it as a webinar, which is really as an appetizer for what we had originally planned. And while ultrasound is just one of a number of adjunctive tools, I think the more we've used it, the more we realize the benefit of it. And this particular module focuses sort of more on brain tumors. And as a test, we weren't quite sure what the response would be, but it's quite overwhelming. And Claire and Google will give us the final numbers, but we managed to fill all the 100 slots that we'd allocated. So clearly this is something we'd look at pursuing further. All right, so in an effort to stick to my time, what I'm going to do then is just welcome everybody and introduce our first speaker. Our first speaker is Aliasar Moiyadi. Just a quick introduction. So Ali is Professor and Chief of Neurosurgery at the Tata Memorial Hospital in Mumbai. It's a unit which performs upwards of 500 brain tumor surgeries per year, so he and his team have incredible experience, especially as it relates to the use of implementation of adjunctive intraoperative assistive techniques and brain tumor surgery. He's published extensively on this topic. He's been invited speaker at various national, international meetings. Is widely regarded as a leading authority in this field. So it's a true privilege to have Ali as part of our faculty, and I'd like to invite Ali to start his talk. Thanks.
Thank you, Llewellyn, for that wonderful introduction. Welcome everybody to this unique web symposium. I wish you all healthy and safe times ahead. So let me just get started with my talk right away. The symposium is on the role of intraoperative ultrasound in brain tumor surgeries, and my brief is to discuss the role of intraoperative imaging in general, and specifically the role of intraoperative ultrasound as it compares to the other modalities. My disclosures, when we talk of brain tumors, the group by itself is very heterogeneous. It consists of many kinds of tumors, and gliomas are the primary intraaxial brain tumors, which are the commonest neurosurgical challenge which all of us face. And I'm going to restrict my talk to the rationale of use of intraoperative imaging in gliomas as a representative case, and it can be extrapolated to all brain tumors. Before we understand the role of intraoperative imaging, it's important to understand the challenges and the aims of treating these tumors or gliomas. And we all agree that we would want best outcomes in gliomas, which means you want to either cure these or you want to have prolonged control for these tumors. And we assess outcomes based on certain prognostic markers. And regardless of the grade of tumor, we know that have certain prognostic factors. If you look at this list, and this is not an exhaustive list, but this is the common prognostic factors and the major ones. The first three, that is age, Karnofsky performance scale, and the molecular profile. All of them are very important prognostic factors, but unfortunately, they are innate and they're inherent factors which cannot be modified. However, what can be modified are the adjuvant therapy and the extent of resection, and that means the quality of the surgery. And as neurosurgeons, Specifically, what is within our capabilities is to optimize the extent of resection. And that's where intraoperative imaging comes into the picture. Now, there's no debating that extent of resection is very important in all kinds of gliomas, be they high grade or low grade. And this has been shown repeatedly. And over the last decade, the controversy which earlier existed as to whether they should be resected radically or no has more or less been put to rest. So how do we go about routine glioma surgery? All of us follow standard steps. There is a planning of the craniotomy depending on the location. There is an assessment of the tumor localization. We plan our entry into the tumor. Most of these tumors are subcortical. We estimate the extent and the delineation of the tumor, assess a safe route to entry, and then we resect it, and then we estimate the resection that we have achieved. We follow general microsurgical principles. All of us have certain techniques, but essentially it's basic microsurgery. And we do a post-operative imaging. Many of us do CT, but the preferred would be an MRI. This is how a planned extent of resection or the plan of surgery is translated into the eventual outcome. But this is easier said than done. When you usually see a glioma like this, it may look well delineated on the MRI, but the moment you open up the brain, you realize that you can't see it on the surface. They are subcortical. And then you are at a loss to decide where to enter the brain. And this is important because it cannot be like an exploration of the brain, because there is a lot of eloquent areas, and these can be variable in different patients. And you don't want to land up with problems which may mean a permanent morbidity or, God forbid, a mortality in some of the patients. And this is not something which is an impression or a personal opinion, but this has been proven repeatedly in studies. And this is just one of the studies which I would like to show, is that when you estimate the resection, or when the surgeon estimates the resection subjectively, intraoperatively, it's not always correct. What they did in this study was they looked at all cases in which the surgeons had estimated a gross total resection, and then they went and looked at the MRI scans and checked whether there was really any residue or was the gross total resection really achieved. And surprisingly, what they found was that in all cases when surgeons called it a gross total resection, residue on the MRI was found in 70% of the cases. This means that your aim has not been achieved. And more surprisingly, in only 1/4 of the cases of patients where there were potentially resectable tumors was a gross total resection really achieved. What this means is that when you have a resectable tumor, you would expect to have a gross total resection. However, it does not always translate into a gross total resection. There may be certain innate problems to that, for example, eloquent areas, but a lot of the times there are misses, as the previous study showed. On the other hand, even in unresectable tumors, it does not necessarily mean that you will not get a gross total resection. And what are the factors which contribute to this discordance between the intent of the surgery and the actual outcome? There could be many steps which may lead to errors during the surgery and the estimation. It could be a craniotomy which is inadequately placed. It could be tumor which is just not visible. And we all know, and all of us who've dealt with gliomas and other tumors know, that sometimes you just can't make out the boundaries. It could be because of hidden critical neurovascular structures, which may, if injured, cause problems. And most often, and this is what the earlier study had also showed, is that the cause of a lot of the residue were inadvertent misses, either in the base of the cavity or on the overhangs of the cavity. And this is what led to the discordance between the estimated resection and the actual resection. And therefore, as neurosurgeons who are driven to perfection, we are always trying to balance this maximal resection with preservation of function. And how do we do that? To maximize resection, we know that our visual capabilities have a limit. Gliomas are notorious for their spread and their diffuse pattern, and we need some kind of augmentation of human capabilities. We have the navigation, we have intraoperative imaging, and we have optical imaging like fluorescence and many more experimental intraoperative imaging techniques. At the same time, we balance that by intraoperative functional mapping and monitoring, whether under anesthesia or as awake. And a combination of all of these leads to an optimal resection in gliomas. I'm going to be focusing on the maximizing resection, and I will just deal with the intraoperative imaging tools that we have and how the ultrasound is positioned vis-a-vis the MRI and the other. Navigation, as we all know, is in layman's term a GPS system, and we all have probably been using the navigation for planning of neurosurgical procedures. However, when it comes to intraaxial tumors, there is the problem of brain shift. And by brain shift, we mean that the moment you open the dura, you release some CSF, and the semi-solid brain substance deforms in a very unpredictable manner, leading to a loss of the accuracy of the preoperatively acquired MRIs, which means the basic principle on which the navigation's accuracy is founded is now no longer valid, and therefore its use intraoperatively to guide further steps of the surgery is going to be difficult. And therefore navigation with respect to brain tumor surgery, especially intraaxial tumor surgeries, is useful by itself only probably for the craniotomy part. For assessing the intraoperative events, you need some kind of real-time intraoperative imaging. And that is where we come to intraoperative MRI. Now, there is no doubt that intraoperative MRI remains the gold standard for imaging of brain tumors, and especially for gliomas. MRI is what we use diagnostically preoperatively to characterize gliomas, and intraoperatively it is extrapolated as an adjunct for assessing the resection. It has been proven in multiple studies, in a randomized study, that it increases the extent of resection and thereby indirectly will translate into improved survivals and outcomes. However, we all also are aware and we know that the MRI is logistically a challenging proposition, especially in the intraoperative setup. It's not only costly and huge initial capital outlay required, but the logistical challenge of setting it up and acquiring a scan every time you need it during surgery defeats the purpose of having an intraoperative imaging tool, not to mention the limited availability of the intraoperative MRI. And this is where the intraoperative ultrasound comes in as a very, very useful alternative. Not only is it easy to use, it's way cheaper than an intraoperative MRI, but it's also more real-time than the intraoperative MRI. And it's quick and can be done repeatedly, and we'll just see why that is so. Now, if I just go back a few years as to when the intraoperative ultrasound came into practice, it was in the 70s that intraoperative ultrasound was used for the first time in neurosurgery. And these are some pictures of diagnostic ultrasound machines of those days. They look quite cumbersome and large, with large probes. And the image quality those days was probably not as good or as optimal as this. However, times have changed. We'll hear a few talks about it in the later part of this symposium. And what we have is wonderful images that are probably as good as the MRI, as you can see here, some different brain tumors, spinal tumors, and you can do many other things with intraoperative ultrasound. So if you were to compare the intraoperative ultrasound head-to-head with the intraoperative MRI, there is no doubt that image resolution in the intraoperative MRI is excellent, and ultrasound is comparable, but probably not as good. The orientation of the image is also better in the intraoperative MRI. However, there are techniques with intraoperative ultrasound. There is navigated ultrasound and 3D ultrasound, which can overcome the problem, and we will hear a talk later in this symposium about that too. Besides that, ultrasound is way cheaper and way faster. You can do that very quickly, updating of your intraoperative imaging repeatedly, and it can be done multiple times. It takes a few minutes. It does not alter the workflow of the surgical procedure. Neither is it inconvenient for the surgical team, including the anesthesiologist, the scrub team, and not even for the patient, especially if you're doing procedures like awake, which is a common procedure in a lot of gliomas. This makes it a very convenient tool, and it is also cheaper. It definitely remains user dependent, and the aim of doing a reversible intraoperative ultrasound is to master the art of acquiring an image and interpreting it. So does this really translate into evidence, objective evidence for the benefit of intraoperative ultrasound vis-a-vis MRI? I'd just like to show you one or two studies here. And this is a study by Geirmund and Tormod. They're both here as speakers too. And way back, maybe a couple of decades back, they did this study in which they looked at preoperative MRI through navigation compared with intraoperative ultrasound, again, navigated ultrasound, and looked at histological characterizations of co-registered biopsies. And essentially what they found was that the ultrasound had better concordance than even the MRI for histology in gliomas and other intraaxial brain tumors, which means that the ultrasound is very accurate. You might say that the loss of accuracy is because of the preoperative MRI and brain shift, but then, subsequently, there is another study, and this study came out a few years back, and this is from German colleagues, and they showed that when they used intraoperative MRI with co-registered intraoperative ultrasound and even fluorescence, and they took co-registered biopsies, and this is a busy table here, but essentially what it showed was that the ultrasound had better concordance in picking up tumor than even the intraoperative MRI, and in some cases, in certain subsets with even the ALA, which means that intraoperative ultrasound is accurate. I'm not saying that it may be more accurate than the intraoperative MRI, but it is at least as accurate, if not better. How does this accuracy translate into real clinical practice? As I said, these are the steps of routine glioma surgery that we do. And we want to aim for getting our actual extent of resection as close to the planned extent of resection. And these were the potential sources of error that we discussed. In order to understand the utility of intraoperative ultrasound, we did a small study by breaking down these steps and devised a scoring system in which we looked at the utility of the ultrasound at different steps of the craniotomy. That means while identifying the lesion, while delineating the lesion, while doing the craniotomy, while doing the durotomy, corticectomy, etc. We broke all of them into useful or not useful, simple dichotomization of the utility. And we studied a group of tumors, around 50 of them, and we looked at individual parameter scores, and we found that it was very high for identification, delineation, and most of the other parts of the tumor surgery, except for the craniotomy, which is not a surprise. And when we took overall scores of all of these parts put together, and you remember these are 7 of them totally, we saw that 80 to 90% of all cases had utility scores above 5 or 6. Which means that the intraoperative ultrasound actually is a very useful tool and a multi-purpose tool, a versatile tool, addressing the needs of the surgeon at different steps during the craniotomy. Eventually, the role of the ultrasound is as good as the image itself. And we will see in the subsequent slides how a good ultrasound image needs to be acquired. It requires a little bit of familiarity with the tool as well as with the image interpretation. Even with a good image, sometimes there are limitations, and that is because of the lack of image orientation. I already alluded to that. And because of that, you're not able to really spatially or temporally correlate serial images. But there are ways to overcome that, especially navigated ultrasound, and we have Gavin talking about that. And that is why ultrasound, when we talk about, is a collection of different tools, including 2D ultrasound, image fusion, co-registered, multimodal ultrasound, navigated ultrasound. And put all together, this makes it a very easy, quick, non-destructive, safe, and inexpensive tool for intraoperative imaging. But remember that ultrasound is just one of the tools in this entire armamentarium, and essentially it needs to be used judiciously in combination with all of these to achieve the final goal, which is to get an optimal resection in brain tumors. Thank you very much, and with that, I will conclude my talk here.
Okay, so thanks very much, Ali. That was really a masterclass in the overview of intraoperative imaging. Just to remind everybody, if you could send your questions either to myself or Martin Schuhmann, and we'll have questions and discussion at the end. So with that, I'm going to hand over to our next speaker, Tormod Selbekk, who will tell us about the basic principles, sonographic anatomy, the indications, and the really how-to for people looking to set up this. So Tormod is a PhD engineer who's had a really prolific career as a research scientist at SINTEF, which is the largest independent research organization in Europe. He's developed numerous innovative techniques, intraoperative adjuncts, working with neurosurgeons at the department at St. Olav's Hospital in Trondheim, Norway. He subsequently moved on to establish various commercial entities, which were direct results of his scientific prowess. So there are few people, if any, in my opinion, in the world who understand the utility of ultrasound in neurosurgery better than Tormod does. So it's a special privilege to introduce him. And Tormod, if you could start your talk now.
I can do. Let's see now if you get the screen up and running. So first of all, thank you for the kind introduction, Llewellyn, and hello to everyone. I will start by actually acknowledging the National Center for Ultrasound and Image Guided Therapy we have in Trondheim. I've been working there for 18 years, closely together with Geirmund Unsgard and the rest of the staff at St. Olav's Hospital. And I've been attending at least 300 surgeries where ultrasound have been used during my 18 years of experience, work experience in the group. So as which was pointed out so clearly in the previous presentation, there are different technologies that you can use for intraoperative imaging. And in brain surgery, you have intraoperative MRI and intraoperative ultrasound as two common options. And of course, there are pros and cons with each of the technologies with respect to cost and acquisition time and setup. And intraoperative ultrasound is easily adapted to the surgical workflow, but you don't have a huge team to support the acquisition. It is the neurosurgeon that needs to acquire the images and also interpret the images. So therefore, it's also important to know some about the basics of ultrasound imaging to get the most out of the system you have available. There are different things that you can use, or there are different procedures where you can use ultrasound. We saw some examples of brain tumor surgeries in the previous lecture, where you can do localization of tumor after craniotomy. You can also use ultrasound for imaging blood vessels, and you can use it for resection control in tumor surgery. You can also use ultrasound in spinal surgery, for example, for localization of spinal tumors after laminectomy. And you can also use ultrasound for image guidance for different procedures, for example, acquiring biopsies or placement of external ventricular drains. You can also use it for navigating neuroendoscopes in fenestrations and so on. And of course, there are also other indications reported which are more research oriented. In Trondheim, we have, for example, used transsphenoidal ultrasound in surgery of microadenomas and macroadenomas in pituitary tumors. So let's start with the basics of ultrasound. It's a quite simple technique, actually. It's a pulse echo technique. So it's about transmitting a pulse and receiving an echo. And the time of flight tells you something about the distance from the transducer or the source to the object generating the echo. And if you have a short delay in time, we will have a close by echo or object, and if you have a longer delay, it will be further away. So this is already used in nature for navigation and their surroundings. So ultrasound is sound with frequencies above the human audible range, so it's above 20 kilohertz. In medical ultrasound imaging, it's usually frequencies below between 2 megahertz and 20 megahertz perhaps that is used. You know that the speed of sound is different in different media. So the speed of sound in air, for example, is a lot lower than the speed of sound in brain. But also for tissues, you may have different differences in the sound velocity. And it's also good to know that sound propagates as compressional or longitudinal waves. So it's a pressure pulse propagating in the medium. So it doesn't propagate as ocean waves. There are two main principles for generating echoes. You can have an echo from the interface between two homogeneous media. There the echo will be originating from the interface. Or you can have an object with internal structures, internal scatter points, where each point is generating an echo. And you can use this principle to generate images by submitting a pulse in a given direction via the ultrasound transducer. And then you're waiting for the echo to return. Then you're sending a pulse in a slightly different direction, and you're waiting for the echo to return to the transducer. And the echoes are transformed into electrical signals by the system and displayed as intensities in the ultrasound monitor. So a brighter intensity means a stronger echo. Another characteristic of the ultrasound images is the scatter or the speckle pattern. And it's caused by echoes from a large number of scatterers. So if you have sending an ultrasound pulse in a given direction, it is a lot of echoes being generated by the structures within the tissue. Some echoes, they might cancel each other out. They are of opposite phase, so you will have a canceling effect. And that will shown as a dark spot in the ultrasound image, while other echoes, they might actually amplify. They can be at the same phase, and you will have a amplification of the signal. And that creates a higher intensity, a higher echo. So in effect, you will have a speckle pattern in the ultrasound images where you have alternating dark and bright pixels close by. And the speckle pattern is not only a product of the object you're imaging, it is also affected by the frequency you're using and transducer design. And there are different ultrasound probes that you can use. You have the flat linear array. Here it is imaging a spinal tumor. And the linear arrays, they usually have a high resolution, but the size of the width of the image is limited by the width of the transducer. And then you have the curved linear array as another category. You have a trapezoidal shape of the ultrasound image, so you can have a larger field of view in the deeper parts, so you can have a better overview. You can also have a quite large near field, but it's limited by the size of the array. Our third group is phased arrays, where you have a very small footprint and 90 degrees sector formats. And for brain surgery, I would say that most commonly transducers with the frequency range between 6 to 12 megahertz is quite often used. It's not a sort of a hard limit. You can have from 5 to 15 and up to 20 perhaps, but it depends on what you would like to image as well. When you're talking about ultrasound images, we can talk about the ultrasound quality, and one important parameter in that respect is the resolution of the image. And the resolution is defined as the ability to separate two closely spaced objects from one another. And it's important to know that the resolution is not only one parameter, a single parameter, but it's defined by the axial resolution, the lateral resolution, and the slice thickness or the elevational resolution. And the resolution is not uniform in all directions, and it will vary with depth. So usually most transducers, they have a sort of a sweet zone where you have the best image quality. So it's also important to select a transducer that is actually having the optimal quality at the depth you're looking at. When it comes to resolution, it is affected by the frequency. So here we have used a hockey stick probe from BK and an ultrasound phantom and did ultrasound imaging at different transmit frequencies. And you can see that you will have a more sharper and more crisp image of the structures with higher frequencies compared to lower frequency. And you also see that the speckle pattern changes, right? Remember that the speckle pattern is also dependent on the frequency. But in general, axial and lateral resolution, resolution will increase with increasing frequency. And then how deep can you image with your given probe? Well, you will have less penetration with the increasing frequency. So if you lower the frequencies, you may have better images of the deeper structures, as this is illustrating as well. I would also like to mention that you could image blood flow inside the blood vessels. You have color flow Doppler imaging, where you can have the flow direction also indicated by the color mapping, and it's the direction compared to if it's against the transducer or away from the transducer, basically. You can also have power Doppler, which is another Doppler-based modality, and it provides higher sensitivity, so you can image smaller vessels. As for any other imaging technology, you will have may encounter noise and artifacts in the images, especially in a surgical setting. One major artifact is the blurring effect, and it's related to the resolution of the ultrasound image. And basically, the shape and size of an object as seen in the ultrasound image is not necessarily an exact representation of its true shape and size. So if you have two objects shown in green here, equally spaced along different depths, in some part of the ultrasound image, it may look like one elongated object. Where you have the optimal ultrasound resolution and best image quality, you will be able to separate the objects perhaps. But if you go deeper, it might again be seen as a elongated single structure. You can also experience enhancement or shadowing artifacts when you're using ultrasound in neurosurgery. You can have shadowing artifacts being caused by calcification, for example. So here I think we have a calcified oligodendroglioma. You can see that you have a strong echo in part of the tumor, and then you have no signal below it. And it's actually calcification preventing the sound to penetrate throughout the whole tumor. So you don't have an image from the deeper parts. Oh, sorry. You can also have enhancement artifacts. So if you have water-filled cavities, you will have a signal enhancement below the water-filled cavity. And this is something you can experience if you're using ultrasound during tumor resection. You need to fill the resection cavity with, as you see here, with saline or ringer to be able to have an ultrasound image. And water has a very low attenuation coefficient. It doesn't attenuate sound much compared to the brain tissue, where you have a quite high attenuation of the sound. So this effect actually causes an enhancement artifact below the water-filled cavity, as you will see as a signal, increased signal intensity. And you can read more about ultrasound artifacts in a paper which is open access at ACTA. Then I will also show some image examples from the brain. So here is an example showing homogeneous liquid, or that is the ventricles. And you see that inside the ventricles you have hypointensic intensity. And you see the falx as a hyperechoic structure. So these are sort of anatomical landmarks you should look for when using ultrasound. Look for the familiar anatomy that you can see and use those to navigate during your surgery. Also, cysts and necrosis will appear as dark areas in the ultrasound image. The tentorium will be a hyperechoic structure. And also sulcus and fissures will be hyperechoic. Gray and white matter. White matter is usually darker than the gray matter. So in the deeper parts of the brain, you will usually see a little signal. As such, it will be dark. So I think that was what I managed on 15 minutes. Thank you for your attention. And that concludes my talk.
Thank you very much, Tormod. That was an excellent overview. Thanks for the quality of your talk, and thanks for sticking to time as well. So it's my pleasure to introduce our next speaker, who Tormod worked very closely with in Trondheim, Geirmund Unsgard. So Geirmund is emeritus professor at the prestigious St. Olav's Department of Neurosurgery and the Norwegian University of Science and Technology in a small university town called Trondheim, where he was chairman for the longest time, and really is credited with transforming this department from a little known unit into a world-renowned department with a reputation as a mecca or epicenter, probably is more appropriate, rather, for image-guided brain tumor surgery. He's had numerous accolades and prizes. Probably the most notable of these was that he was knighted by the King of Norway for his work. So we are incredibly honored to have Gavin as part of our teaching faculty, and I'll invite Gavin now to talk to us about intraoperative ultrasound in glioma surgery. Thanks, Gavin.
Thank you very much, Llewellyn, for this very beautiful introduction. Yes, I'm going to speak about intraoperative ultrasound based on my experience from everyday use of that equipment for many years. I have a disclosure, medical advisor for Sonoclear. I have navigated 3D ultrasound since 1996. I've used this equipment, Son1. When we built our new neurocenter in Trondheim in 2005, we had the chance to get an intraoperative MR. But we decided to use 3D ultrasound because we had much positive experience with it. It's the low capital cost, it's the imaging hazard, no imaging hazard. It's the short time to get an ultrasound image, 30 seconds. And it's also the soft tissue quality, which in my opinion, is very good. The only challenge is learning is needed to benefit from intraoperative ultrasound, and that's why we have this webinar. And also that's why we had these training courses in Trondheim for many years. And I'm going to go a video from course to show how I like to use the ultrasound image. This is a patient with the tumor immediately behind the central sulcus, acquisition from the dura, showing the tumor very well, I think. You can see the diffuse borders of the tumor. Then it's time to get the biopsy. And when you do the biopsy, you set the target, and you also see how inaccurate the MR really is. And then you also see here how much brain shift you get. The brain is falling down, and this is the surface of the brain. I like to use navigated CUSA for resection. In that way, the tip of the CUSA is always in the image. The image is changing all the time, and you can see the borders of the tumor and relative to the CUSA tip. Different stadium of the operation, and towards the end, the resection control, showing that everything is removed. And that was also confirmed by the MR postoperative gross total resection. This is another patient with a big glioblastoma. And here you see the shift of normal tissue. Different stadium of the with ultrasound, some tumor tissue left, and at the end, everything removed. And the day after, MR showed that a cavity that was much smaller than the original tumor, demonstrating the brain shift. The most important point for ultrasound-guided operation, image quality. You can see all the details in an ultrasound image that you can see on the MR image, I think. It's easy to obtain good image quality before start of resection. It's more challenging during the resection. You have to take care of some requirements. One of them is optimal positioning of the patient. It's always possible, in my experience, to position the patient to obtain a horizontal craniotomy. And the other requirement is that should have a clean cavity without spular pannings or blood to obtain a good image. Ultrasound and navigated pre-op MR have different strengths and limitations. While navigated pre-op MR have a large overview, it has a lousy accuracy. And intraoperative ultrasound have a high accuracy, but a limited overview. And the overview of the MR and the accuracy of the ultrasound can be combined with 3D ultrasound. The navigated 3D ultrasound can be fused into the pre-op MRI volume or compared side by side to corresponding cross sections. In that way, you can compare with MRI, which can be beneficial. You can immediately see the brain shift here. You can, it makes it easier to interpret the ultrasound image. Like here, you might suspect that this is an artifact from this cyst here, but by looking at the corresponding cross sections from the MR, you see that this is a tumor. You can follow the progression of the operation, different stadium of the operation, and the progression of the operation have reduced the problem of the enhancement artifact. This is the same patient as on the previous slide. More of the tumor is reduced, and at the end, everything is reduced. But there is a new signal coming up here. And what is that? Yes, by comparing to the previous image, you see that this is an enhancement artifact. Another way of handling the enhancement artifact is to use a small high-frequency probe into the cavity. That will reduce the distance and to the wall, and that will also reduce the noise. The disadvantages are reduced field of view, it's cumbersome to use, and has the potential risk of harming the tissue. A more elegant way of handling the enhancement artifact is to use coupling fluid that has the same damping effect as the tissue. As Tormod told, the attenuation coefficient of water is very low, and the attenuation coefficient of brain tissue is rather high. And this creates this chaotic signal below the water-filled cavity. By filling this cavity with acoustic coupling fluid, you can see details that you otherwise would not see. I did phase 1 technical study technical safety study of this fluid on 15 glioma patients. And the adverse events of this study were within the limits of what have been reported in other glioblastoma publications. And the quality of the images, you can see by yourself. This is a glioblastoma. And you see towards the end of the operation, with ringer in the cavity, it's difficult to see whether you have some residual tumors here. But with acoustic coupling fluid in the cavity, you can easily see this residual tumor tissue, and you can see that there is no tumor tissue along the corpus callosum here. Another case, after having removed some of the tumor, you see there is residual tumor on the side of the probe. On the other side of the cavity, it's very difficult to know what is going on. But by filling the cavity with acoustic coupling fluid, you can see the satellite tumor. You can also see there is some residual tumor below the sinus here, the pulse. As I said, I like to use navigated CUSA for resection, especially in the subcortical lesions, like in insula glioma. The usual way of operating these insula gliomas is through a Transylvian approach. I think it is more elegant to use transcortical approach and do the resection guided by navigated 3D ultrasound. You can make a very small opening in the cortex, and then after some resection, this is how it looks like. Some tumor tissue left. You can also do angiography to help you localize the insula vessels. You have to operate in between the insula vessels here, but that is actually very easy. And at the end, everything is removed. You see the insula vessels hanging freely in the cavity. And you see this opening in the cortex is very small. And the patient was very well with no neurological deficit only a few hours after the operation. And this is on her dominant side, the left side. I also, the navigated CUSA is especially useful in deep-seated lesions, like this tumors, amygdala tumors of these two patients, one on the right side and one on the left side. This one on the left side was operated at another hospital through a Transylvian approach. They didn't get to the tumor, actually. This is the scar from that operation. And this is how it looks like the day after operation for both patients. Gross total resection, no neurological deficit, and this patient had a hardly noticeable paraphasia. The way I do it is to go with a linear incision temporarily, and then make a craniotomy as close to the zygomatic arch as possible. And then do the ultrasound image, and then go with the navigated microscope and the navigated CUSA, and identify and then start to do the resection. After some resection, you can do a new ultrasound acquisition. You see the channel, and you see the residual tumor, and then you at the end everything is removed. This is an artifact. I think it's a blob at the bottom. So what results do we get on low-grade glioma operations? I think many of you have heard about this article where we compared two strategies for operating low-grade glioma in two different university hospitals. The Jaakkola, the first author, was the PhD student of mine at the time when he wrote this article. And I was the one that did the early surgical resections. And the way why this was possible to do is that we have a free healthcare in Norway with a regional organization, and all surgical patients are referred to their own university clinic. I did the operations with 3D ultrasound guided technique on asleep patients. And this is a robust material because every patient that was referred to our clinic, our university hospital, is included. And the survival is 14.4 years, while the median survival of the other hospital was 5.8 years. And there was no difference in adverse events of the two ways of doing it. So another PhD student, a radiologist, went through my material from 2008 to 2015 on standard resection in low-grade glioma. These are also a robust material where we try to operate every patient if it was possible to remove at least some of the low-grade glioma tumor, even though it was evident that it was impossible to do a gross total resection. All these were done asleep with 3D ultrasound technology. The median resection grade was 93%, gross total resection was 30%, and the median residual volume was 1 milliliter. So, and the quality of life was maintained or improved in 86%. So the conclusion of this article was that 3D ultrasound guided low-grade glioma resections under general anesthesia are safe. And the extent of resection is also consistent with published studies using other advanced neurosurgical tools. So you don't need intraoperative MR, or you don't need to operate your patients asleep to get optimal results on low-grade gliomas, in my opinion. Thank you.
Thanks so much, Geirmund. It was really a fantastic talk, and we can see the contributions you've made. I think that the Yakulo paper of yours, most neurosurgeons around the world are familiar with it. Okay, and thanks for sticking to time as well. So our next speaker is Gavin Quigley. So Gavin is a consultant neurosurgeon in Belfast in Ireland, runs a very busy unit which deals with the full spectrum of neurosurgical conditions, so both adult and pediatric. He's got a long-standing interest in the utility of ultrasound in neurosurgery, specifically 3D integrated imaging. He's taught at numerous neurosurgery workshops, been an invited speaker around the world. So we're really delighted to welcome Mr. Quigley, who's going to speak next. Thanks, Gavin.
Good morning. Thanks very much. I hope everybody is staying well. I'm going to get on in the interest of time. I'm going to set my little watch so that I stick to time. So just my disclosures, obviously. I just wanted to be clear to everyone that what we're talking about is not new or revolutionary. It's been around, and if you look back at the date of this publication, you'll see that it dates to the era where ultrasound came out of sonar technology in the US military. Lyle French became the professor of neurosurgery in Minnesota. John Wilde is described as an eccentric Englishman who was interested in obstetric ultrasound, and Donald Neal was an engineer who'd served in the US Navy. So none of the stuff that we've talked about is particularly revolutionary, and it hasn't been done before. What has improved really is the quality of the image. And again, some of these things have been shown before. Co-registered ultrasound combined with navigation is a useful technique. I think you'll get the feeling from all of us that that's something we all firmly believe in. I'm going to divert slightly for a minute just to say why ultrasound. I mean, you've heard some of this stuff before. It is easy to use. It is low cost if you compare it to some of the more advanced techniques. It's portable, which is a big advantage. Brain shift correction, and I think importantly, you can reassure yourself that what you're looking for is underneath the dura before you commit yourself to opening the dura. We've seen the focus of this talk really has been on tumor surgery, but you can imagine that there are multiple other uses for ultrasound. One of the important things that we will normally go over in detail at the hands-on course is what things appear on the screen. So one of the things that you really have to get your head around is this concept of echogenicity and homogeneity. So we're looking at how bright the echo is or how dark the echo is, and also whether it's homogeneous or not. And you can see that different types of tumors and intracranial lesions have different characteristics, and that reassures us that we can visualize those with a degree of ease. The most important bit of this slide really is at the last piece of writing, and that draws attention to the fact that ultrasound, unlike CT, where you have definitive values for each pixel, if you like, is not the same as that. What you're looking at is a grayscale that you're able to adjust, and it's not a calibration scale. And I think this is one of the challenges sometimes people face, that they look at ultrasound and say, oh, this signal is definitely this, but of course that has changed. Each day you use the ultrasound, it changes on the variety of machine you use, and of course it changes because you may have adjusted the gain. So it's important that what you're looking at really is the differences between high echo and low echo, and it's that variation that gives us the ultrasound image. We would normally say that anything with a cyst, where there's a contrast between fluid and solid tumor, is easily visualized. Intracerebral hematomas are very easy to visualize. We rarely these days remove intracerebral hematomas in the UK, but I know that that's not the case around the world. It is a very useful technique to put the ultrasound on, visualize the hematoma, check with the Doppler if there's any evidence of biphasic flow. So in other words, you might have an underlying AVM, because I don't know about the rest of the world, but I only ever see intracerebral hematomas at night. They never present in working hours. And the last thing you want to get into is an AVM in the middle of the night. And ultrasound allows that sort of reassurance. You've already seen pictures from Ali and Geirmund and Tormod about high-grade gliomas and low-grade gliomas. They're very easy to see. Meningiomas, even if they're superficial, are incredibly easy to identify because they're fairly uniform by and large. Obviously, they can have calcification and things, but it's not a particularly difficult thing to visualize. What you're really looking for with meningioma surgery is things like power Doppler to work out where the vascularity is. You can see here just a comparison, of metastasis, and these are the three types of image you'll see. You'll see your classic T1 contrast MRI, the T2 MRI, and then the ultrasound overlaid, and that's really what we have been talking about, is this three-dimensional ultrasound. Now this is requires preoperative imaging to be combined with an ultrasound scan through one of the navigation systems. But you can see that typical lesions that we see every day show up extremely well on ultrasound. Glioblastomas, low-grade tumors. Now this is a particularly well circumscribed one, but what you can see on this image is the low density of the brainstem. And I think it's one of those structures that you get used to seeing in ultrasound images. You don't quite believe it yourself, but actually the brainstem is consistently this sort of homogeneous, low echogenic structure, and you will see it. And as brain shift improves, you'll begin to recognize it. anything with a cyst generally turns up. Pilocytic astros, obviously with their relative cellularity, tend to have this more solid looking appearance, and that can be extremely useful because you may look at this image and say, well, this could be a cystic hemangioblastoma, and that might be our little mural nodule. But the fact that it's so solid looking would draw you against the sort of mural nodule theory and suggest that what you should be trying to do is to completely resect this pilocytic. Anaplastic tumors, again, anything with cyst, different types of tissue within the tumor will show up extremely well. Cavernous lesions are very easy to find, and that's one of the, I think, the big uses for many of us is looking at things like cavernous lesions, because we know that they can be relatively small, they're frequently deep-seated, and they can be difficult things to find. And I think, as Geirmund showed you, you can see, you can visualize your tract as you move towards the tumor. And what ultrasound does is give you that live reassurance that you're looking at in the right direction and that you're heading towards the tumor. Abscess, we see very few of these, but clearly in other parts of the world, these are you know, a recurring problem. We will probably see 1 or 2 brain abscesses a year for our 2 million people. But ultrasound is extremely useful. Cystic lesions, very easy to visualize. So why aren't more people using ultrasound? Well, I think because it's a freehand technique, we do occasionally see images displayed in very unusual orientations. It is different to CT and MR. There is a lack of knowledge about both the gain and the focus, but also the scanning practices. I think some people have touched on this. It's crucial that we get good acoustic coupling for a good image. And that's partly through patient positioning. It's through use of fluids and saline, but it's also understanding a little bit about ultrasound. And there are clear gaps in ultrasound training around the world. And that's one of the things that we, as a group, have felt, I think, obliged to try and rectify. It doesn't take a huge amount of effort to learn ultrasound. It just requires practice and a bit of patience. In the past, some of the three-dimensional ultrasound things were quite difficult, and the setup and workflow were complex. And you'll see that Geirmund was demonstrating a purpose-built scanner. Those, unfortunately, the SonoOne system is no longer available, so we've had to look at what we can do going forward. And I'm going to show you a little bit. This is the newest version of the BrainLab software. And you'll see that what you've got is your preoperative MR. And on the left-hand side of the screen, you've got a standard ultrasound scan, but it's reconstructed in the axial, coronal, and sagittal planes so that it's much easier for you to visualize the ultrasound scan in the same way as you would look at an MR. And I think that for many people is the challenge. They see the ultrasound scan and they can't visualize it in the same way that they would look at an MR or a CT scan. Geirmund showed this scan. Lots of advantages for ultrasound, cost, speed, moving the patient, all of the things. I mean, obviously, if you have a center with an intraoperative MR scanner, that's fantastic. But we would encourage you to, even before you go ahead and do your intraoperative MR scan, a sweep with the ultrasound scanner will make sure that you have identified any obvious residual tumor before you go to MR, because the last thing you want to do is go back and forward to MRI chasing small fragments of tumor. Just a little comparison. This is the sort of images you'll see. You've got ultrasound, CT, and MR intraoperative scans, and you can see that the ultrasound is just a bit easier to work with. So integration with image guidance. This is now fairly straightforward. And what it allows you to do is to create a three-dimensional ultrasound image that you can then navigate from in the same way that you use the pre-op CT and MR. This is the slightly older version of the BrainLab software from one of our low-grade glioma patients. And you can see that you can overlay your standard T2 images. We've got our tractography data there. You can also overlay fMRI if that's your wish. And what we will do is try and resect the tumor in quadrants, or whatever particular method you choose to resect tumor in. Some people work as a clock face. They start at 12 and work round. We tend to work in quadrants. So we take away a quarter of the tumor, we scan, and you can see that the bottom axial image shows a sort of quadranted resection from the ultrasound overlaid on top of some of the image data. And you can see that if you stage that over sort of every 20 minutes, you're performing a scan, that allows you to get a better idea. Brain shift we talked on, it's difficult, it's non-linear, it's worse if you've got superficial lesions that are very swollen. And you can see on these older images, this is our low-grade tumor. You can see the edge of where the preoperative tumor is drawn. And the reality is that there has already been about 1 centimeter of brain shift. And this is purely opening the skull. We haven't actually opened the dura at this point. In this image, this is a hematoma cavity that was thought to be a cavernoma. And you can see that once you've opened the skull, the brain has already moved upward. And this image shows a parafalcine lesion, which the orange image is the new, if you like, the reality, and the preoperative image is the red one. And you can see already, just before we've even opened the dura, how much shift there's been. Again, some people, I think Ali probably touched on this. We've looked at ultrasound in the past. The image quality of ultrasound scanners 25 years ago was not comparable to the quality of scans that we see today. And I think that's probably the most important development. And really that's about the graphics processing. And we now have ultrasound scans that look at least comparable to CT, if not MRI. So the co-registered ultrasound, and just for 2 minutes, do this very quickly. If you can register your ultrasound with your navigation, it makes it much, much more intuitive for you to work out what you're looking at. It removes the spatial disorientation, it speeds up your learning curve, and you have an immediate idea of what the brain shift is like. Once you've done it, you can take the ultrasound probe out and simply work from a navigated ultrasound scan. And this is what the new BrainLab system will allow you to do. You can see here there's a periventricular lesion. This is the ultrasound. And if we overlay the previous things that we've drawn, so the falx, vascularity, ventricles, things like that, you can see that those all fit on top of the ultrasound. You can see there is a degree of shift already. We can even put where the sagittal sinus actually is, and you can see it running down towards the torcular there. And you can see how much shift there has been. You can overlay your images in 2 dimensions for very quick navigation. And you can see here that the ultrasound scan confirms essentially that what you're looking at is identical to the MRI scan. The new scan will allow you to see the new app, I should say, will show you multiple planes of MRI. You can change the transparency. It automatically shows you the equivalent MRI scan, and the screen jumps sort of without you having to do much. And essentially, all you need to do to acquire your scan is fill the cavity with water, let the bubbles disappear, and then you can see that what we're going to do is a 3-dimensional sweep. We're going to move the probe steadily. The probe has to be tracked with an adapter and one of the navigation arrays. And you can see then we get the last of it. And that then automatically allows the computer to create a 3-dimensional volume that you can then navigate from. And it really is as simple as that. It does require practice, but if you can possibly manage to use navigation with your ultrasound, you will learn how to benefit from ultrasound a great deal more quickly than you would if you were simply using ultrasound by itself. And I am going to stop there because I think that is probably time. Thank you.
Okay, thanks, Gavin. That was a fantastic talk. Thanks for that overview and the historical perspective. So Ian Donald's contribution was profound, and thanks for mentioning that. Just a reminder that Ian Donald did that work while he was in South Africa. He did his master's degree at UCT. Anyway, thanks so much, Gavin. Our next speaker really takes the sort of session to the next level. So Francesco Prada is a neurosurgeon based at the Carlo Besta Neurological Institute in Milan, where he currently serves as director of the Ultrasound Imaging and Therapy Lab. He's a stellar example of a surgeon scientist. He's got vast experience in treating tumors of the brain and skull base. He's published extensively on advanced ultrasound imaging and therapeutic techniques. He's also served as the Merkin Scholar at the University of Charlottesville in Virginia and the Focused Ultrasound Foundation. So it's really an immense pleasure to introduce Francesco. Francesco, do you want to get started?
Sure. Thank you, Llewellyn, for your generous introduction. So these are my disclosures. In the past presentation, we heard a lot about ultrasound in neurosurgery, and what I would like to point out and discuss in this presentation is the fact that ultrasound is composed by different imaging modalities. We mainly talk about, when we talk about ultrasound, we mainly refer to B mode, so to the grayscale ultrasound imaging. But as I said, there are many other modalities such as contrast-enhanced ultrasound and elastography, which I would like to discuss in this presentation. It's just not adding some fancy colors. These are modalities that can add really valuable information that can improve our surgery. For example, they are the gold standard. Contrast-enhanced ultrasound is now the gold standard for the diagnosis of liver lesions, hepatic lesions, and elastography is becoming the gold standard to assess benign and versus malignant nodules in thyroid and breast. So why there is a sort of, we are lagging behind what is happening around us. The main reason is that the brain is encased in the skull, and as we all know, the skull reflects and absorbs 90% of the energy, and it doesn't allow to perform imaging except for some tiny windows. Another reason that has been extensively discussed in the past presentation is the fact that sometimes we start with the low-end equipment, not very sophisticated systems. The image quality is poor, and we start thinking that ultrasound is not such a good imaging modality, but instead we need to have a high-end ultrasound system, because you need to have, in order to perform contrast-enhanced ultrasound and elastography especially, you need to have a specific algorithm and modality built in within your machine. And also, you need settings. You need to set these, the machine properly, and this can be done easily together with a vendor, for example, or working with some colleagues, radiologists that currently use this kind of equipment. Knobology is really important. So the important thing is to keep it as simple as possible, and when you have the proper setting at the end, you just have to press a button and you can start your examination with contrast and or with elastography. One other issue is that the costs. So high-end ultrasound systems are more expensive, of course, than regular ultrasound devices. But we have to keep in mind that our OR are nowadays equipped with all sorts of equipment, which is usually very expensive, and compared to regular neurosurgical devices, ultrasound systems are usually really cheap. We can say cheap. So occasionally they can be sold at very high prices to us neurosurgeons. I don't understand why, but usually ultrasound systems are quite an economic solution. And also the image interpretation, when we talk about contrast-enhanced ultrasound and elastography, is not straightforward. Here you can see a sagittal view of a frontal glioma. Here on the right, we can have a look at the parasagittal meningioma, as it appears with an elastographic region of interest superimposed. It's not straightforward, the understanding of these images, and we need, of course, some training. Very useful is when we have the opportunity to use fusion imaging and navigation and compare, especially when we start doing this examination, when we start comparing directly an unknown imaging modalities such as contrast-enhanced ultrasound to familiar imaging modalities such as MR, and the same for elastography. So what are the advantages after all this problem that we have to face when we start with these new modalities? The first is for sure that we can gather a lot of information, and I will show you some example afterwards, that improve our surgical strategy and surgical guidance. And there are similarities with other imaging modalities that we use currently. So this is a T1 MR of a parietal glioma, and no one would perform surgery relying only on, nowadays, or relying only on this image. You will ask for contrast, you will ask for a T2, flare, perfusion, whatever, functional data. At the end of the day, this, I think, it should be done also with ultrasound. So we shouldn't rely to the mode only, but we should try to get information about perfusion of the tumor, or the surrounding parenchyma, and visualize the vessels with contrast. It would be very helpful. It's very helpful also to visualize and confirm the mode findings with elastography and with ultrasensitive Doppler, for example. And the other reason is research. As I said, the bone is shielding the brain. So the brain is a sort of a holy grail from an ultrasound perspective. And we have the privilege, every time we perform a craniotomy, to open a window, an ultrasonic window to the brain. So I think it should be, it's our duty whenever we do our surgery, not only to perform safely the surgery, but also to gather as much data as possible. And I like so much the idea of the window that we are developing a skull replacement to be implanted at the end of surgery in order to perform follow-up with ultrasound in patients after surgery, and also this will allow to perform ultrasound-guided therapeutic approaches, but that's not the topic of this presentation, just to give you a highlight. So very quickly, contrast-enhanced ultrasound. First, in order to perform contrast-enhanced ultrasound, you need an equipment, but you also need the contrast. The contrast is our gas-filled microbubble with a phospholipidic layer that, as you can see in the video, when they are hit by the ultrasound, they start to vibrate. And they generate a specific signal, which is read by the ultrasound system. And the algorithm shows on the display only the signal generated by the microbubble, and all the other imaging, all the other signals are suppressed. They are injected intravenously at the moment of the evaluation by anesthesiologists usually. And their use is regulated by many guidelines, and there are 3 parameters that are the most important: the timing, so how the microbubble arrives and fade away, the degree of the enhancement, and the distribution of the contrast. This is an example of what we can see on the screen of our ultrasound system when we perform microbubble. This is a coronal view of a frontal metastasis. You can see here the interior complex. The tumor is highlighted in its perfused portion. whereas the necrotic area is not perfused. As you can see, just tilting slightly the probe, we can follow the vessels along their path, which is an advantage over Doppler, of course. And another advantage is that we can visualize high flow and low flow vessels at the same time without the need to adjust any parameter. It is possible to visualize all kinds of brain tumors, from gliomas, various tumors such as hemangioblastoma, ependymomas, metastasis, meningiomas. Anything that has is perfused can be visible, and also we can see in negative what is not perfused, such as radiation necrosis, for example. It is possible with contrast to characterize brain tumors. Here you see how the glioma group looks different. So in the upper row we have low-grade glioma, in the lower row we have high-grade glioma. You can see how the morphology and the degree of enhancement, as I was mentioning before, is different, excuse me. And also here in the diagram, you can see how the peak phase is much faster for high-grade glioma compared to low-grade glioma, and this is evident because of all the shunts present in the tumor. If we use fusion imaging, so we did a study comparing microbubble imaging to gadolinium-enhanced MR, and we found out that the morphology showed by the microbubble is superimposable to the MR. So microbubble can be used, at least in glioblastoma, as surgical guidance to tackle the tumor. And also, they can be repeated multiple times throughout the surgery. And in fact, they are able to highlight tumor remnants in the surgical cavities. In this case, you can see here that there is this enhancing portion that is highlighted. It's very useful also as a contrast agent for angiography. This is a sort of an angiography of the polygonal wheels performed with ultrasound. Of course, in vascular cases, it's very helpful. It highlights the aneurysm in this case. But even after clipping, it's very helpful, and we're conducting a study on that because you can assess the distal arteries, the patency of the distal arteries, and also because we have a tomographic section of the brain, we can assess the perfusion in depth after comparing before and after clipping or any vascular procedure. And in a skull-based lesions, such as this sphenoid wing meningioma, it is helpful not only in highlighting the tumor and resecting the tumor. I mean, this tumor doesn't need to be highlighted, but it's very helpful in visualizing and localizing the vessels in the surgical field and assess their patency after surgery. And with microbubble, we can also highlight spinal tumors with some differences with MR, because since the microbubble are purely intravascular, they do not extravasate, such in this case of hemangioblastoma, where we had a nodule, but with a contrast on MR, which was not visible in with ultrasound. So for the first time, 2 years ago, the use of microbubble in neurosurgery have been included by the guidelines from the European Federation for Ultrasound in Medicine and Biology, which is comprised by a large group of experts in microbubble imaging for all organs. They found out that the use of microbubble is very useful, but the level of evidence is, of course, really low, because the numbers on which radiologists play are by thousands compared to the few cases that we have. So I hope that in the future this will be an adopted technique in order to generate more consensus. Very quickly, elastography. It's a method that allows to translate manual palpation into imaging performed with ultrasound, and this happens because we can generate a wave of distortion of the parenchyma that is able to generate a transverse shear wave, And the machine is able to visualize on the screen these tiny deformations with a very high sensitive, in a very high sensitive manner. We can generate the stress with a strain, with applying pressure with the probe, or generating the force with the ultrasound. This is what we see on the screen. This is a metastasis where we are, we can superimpose a region of interest over the tumor and the brain, and we can see how the tumor is firmer compared to the normal brain on a colorimetric scale. Again, as for contrast, we can visualize different kind of tumor, confirming the findings on B mode, which are not always straightforward. There is, in fact, a very good correlation between elastography and B mode, the impression of B mode, and the elastography is able to eliminate doubt related to, for example, brain edema. And it's, again, as for contrast, we can characterize brain tumors. In fact, we found out in a series of 70 cases that low-grade glioma are stiffer than the brain, whereas high-grade glioma tends to be softer. So, all in all, at the end of the day, if we apply all these options, imaging options, we can really perform a multi-parametric intraoperative ultrasound that provides us with information on morphology, orientation, tissue perfusion, vessels in the surrounding, mechanical properties. And all of that is in real time. And with that, I'm done, and thank you for your attention.
Okay, thanks, Francesco. It was a really great talk. We was a little over time, just a few comments. So Claire, if I'm correct, this has been recorded, and you let everyone know how to get hold of the recording at some point. So I'm going to introduce our final faculty member, Martin Schuhmann, who's going to chair the discussion for us. Martin's professor of neurosurgery and chief of pediatric neurosurgery at Tübingen University Hospital in Germany. He's a leading figure in academic pediatric neurosurgery throughout Europe. And as a result, he's scientific co-chair for the European Society for Pediatric Neurosurgery. So Martin and I also run jointly an annual teaching workshop based in Tübingen, the International Workshop on Ultrasound in Pediatric Neurosurgery, which is in its 4th cycle this year. Tentatively scheduled for November, but we'll have to see how things play out this year. So it's really a personal pleasure to invite Professor Schuhmann, or as we like to say in South Africa, Schuhmann. So Professor Schuhmann, I'm going to invite you to chair the session. We've got some questions already, I think.
Thank you very much for the kind introduction to chair or to discuss now these fascinating presentations we heard. I learned a lot, and I hope the visitors, or the 64 participants I can see on the list, had the same experience than I had. So if everybody wants to ask a burning question, I think we should just go ahead.
So Martin, we've got, I think they sent some private questions. I've got a question from Rohan Harichan Prasad, who's a consultant in...
I can't see any in the chat here.
Okay, KwaZulu-Natal. So maybe I'll just read his question out. Ro, do you want to unmute yourself and ask the question yourself?
Yeah, thanks, Llewellyn. Thanks for all the presentations, firstly, they were great, and thanks for the webinar. My question was regarding to what's currently available in radiology with regard to ultrasound machines that are there, and what can you do with that with regard to intraoperative imaging without having to purchase extra equipment. So if I go to radiology now and find out what ultrasounds they've got, can I push one up to theater? What can I do with it?
Okay, any from the faculty, any advice? Can we use a standard radiology machine?
My advice is yes. Do it, go there, get your machine and get it. Because, for example, the machine I've been using for 10 years have been developed by radiologists who were performing navigated biopsy of the liver. So you just have to turn it to use it the opposite way around, and you're done. And usually in a radiology department, you can find machine equipped with contrast-enhanced ultrasound and elastography, because they are becoming the gold standard for many organs.
Any other?
Yeah, if I can add to that, Martin.
Yes,
Yeah,
yes.
so I think it's what Francesco said is correct, that if you're going to start using it, you should use whatever is available. And as you use it, it will grow on you, and you will realize that there are options of different probes with the same machine probably. So it would be worth investing in the probe rather than the entire equipment. And as you go along, you will realize that there are certain advantages and disadvantages. And you would then be sensitized enough to look for a dedicated machine for your kind of work. So I would agree that yes, you use the one which is there in radiology, but sometimes you may not have all the probes available there, in which case you might risk discrediting the intraoperative imaging because you don't have the right kind of probe. So be aware of that, especially when you start off. And it may be a good idea to have the radiologist with you if they are amenable and friendly enough in the operating theater to help.
Yeah, I think just to say, if you check with your urology department or the gynecology pelvic floor, those type of places often have ultrasound scanners that are suitable. And as Ali said, it may be a question of just changing the probes.
I think you should go for to have your own machine as fast as possible, because the ultrasound equipment should be at least part of the equipment in any neurological department. That is my opinion, at least.
Yeah, I certainly agree. Only if you have your ultrasound machine available in every case, you will get used to it, and everybody will get used to it. But to get the taste of the opportunities and to really kind of smell how good ultrasound is, it's a very good thing to borrow the machines. So, and get people convinced, get your chairmans convinced that this is a real addition to and belongs to the neurosurgical armamentarium.
Yeah, if I could just add to that, Martin, those are great points. The one thing that people sort of starting out often ask is, how do you drape the machine? How do you use it intraoperatively? So Ali, I know previously you'd had a great video on that. So maybe we could just add that, if you don't mind, as content, you know, on how to position, how to drape. Getting a radiologist in theater is very useful if you're a magician. But I would suggest you kind of use that early, but get proficient with it, you know, yourself. Otherwise, you're just going to create an additional variable. So, Martin, I've got another question that I'm going to read out here, if it's okay. So, Jacinta Francis from, so Jacinta, if I get this correct, you're from Malaysia, but currently in Cambridge doing a fellowship. Why don't you unmute yourself and ask the question yourself, Jacinta?
Oh, hi, everyone. Thank you for such an informative webinar. I'm actually doing a fellow in pediatrics with Professor Mehmet Ozek in Turkey, not in Cambridge. So my question was actually about elastography. I'm actually quite fascinated with it because you mentioned about its different elasticity between different tumors. And I wanted to know, in regards to low-grade gliomas, can we actually tell the extent, and it helps us to see the extent of residual low-grade glioma, which we find it very difficult. And now we have fluorescence to help us, but what is the outcome of this with ultrasound? Thank you. And my second question was actually the acoustic fluid, coupling fluid that was mentioned by Professor Geirmund. I wanted to know what constitute the acoustic coupling fluid that he used. Thank you so much.
So maybe Francesco, you answer these questions.
Yeah, I'll answer the first part regarding elastography. So yeah, we proved that with elastography, it's possible to delineate the boundaries of both low-grade and high-grade gliomas. And there is a correspondence between our data and the intraoperative findings, let's say, from a tactile point of view. It has to be said that, especially in temporal lesions, where we have the area where the infiltrative area, the imaging is not totally straightforward in certain areas. And also it depends on the elastography modality that you are using, because we have available only strain elastography at the moment, where the strain is generated by the brain pulsatility and the pressure applied by the probe. Another imaging modality is shear wave. It's called shear wave elastography, and the strain is generated by the ultrasound itself. So you can generate a quantitative result, and it's much more precise. In general, with the strain elastography, you have a very good correlation between the B-mode impression, and so you can confirm that. For the residual tumor, we did some tests, but with strain elastography, since you have to apply pressure on the brain, which has been traumatized by the resection, we didn't dig much into that. I think shear wave elastography is much more suitable.
Yeah, I think that is a very good point, because also from my experience, it's not so easy with the elastography, and I was quite fascinated to see your very nice delineation. So we are using a BK also with the strain elastography, and at least as a beginner, and I'm talking here from a beginner's point in elastography, it's quite difficult to really, in a low grade or a softer pilocytic, for example, to really get a good delineation in the elastography imaging. So I think there's a lot of art behind it, and it's not an easy, straightforward thing.
No.
What is your maybe advice?
I totally agree with you. It's in some cases it's not always possible to get a nice elastogram, especially with the strain elastography, where you have to vibrate and probe a little bit. I think shear wave elastography would be much more suitable, where the strain is generated by the ultrasound. There is no movement involved, and you can also have a quantitative result. So you can quantify the differences in elasticity. Yeah. Then we still have to correlate it with the degree of infiltration and whatever, but at least you get numbers.
Good. Any more questions on your screen, Llewellyn?
There was the question about acoustic coupling. Maybe Geirmund, you want to take that?
Yeah.
You need to switch on your microphone.
Yeah. I can answer. I want to add a comment to Francesco's description of the low-grade glioma. In my opinion, you also see very well the borders of the low-grade glioma with B-mode. It tells the B-mode is reflecting the number of cells in tissue, and when the number of cells is increasing, then you see more signal from the B-mode, and it in a way tells you how diffuse the borders can be in low-grade glioma sometimes. So it is useful also to use a B-mode on low-grade glioma. I always use that.
Again, I didn't say that B-mode is not useful. I mean, B-mode is the first modality that you should use. Yeah. With elastography, you can have further information of the mechanical properties of the tissues first, and then you can confirm that the findings that you are getting with B-mode. Yeah. So in one of our slides, we found that there is a 95% correlation between elastography and B-mode. Yeah. But whenever in high-grade gliomas where you have edema, for example, it looks similar to the tumor from a grayscale standpoint, but when you turn microbubble or elastography on, you can see only the vital portion of the tumor. So it's I mean, of course, I agree. B-mode is the first modality that has to be used.
Yeah.
And then
to answer the question of Jacinta Francis is currently, without having acoustic coupling fluid available to the majority of people, and
Well,
also with the distortion of the mechanical properties by surgery, the elastography is not going to be the mode or the opportunity to identify residual small aspects of low-grade tumor, probably.
Can I answer the question about acoustic coupling fluid? This is a fatty emulsion that has been patented all over the world, actually. It's now in production, and hopefully it will be commercially available in one year about. So
we're waiting for it.
Yeah. Very good.
Because I think this will be the very big step in resection control is the acoustic coupling fluid for these small residuals, taking away the enhancement of the different speed levels.
Yes, yes. Okay.
Okay, any more questions to maybe 3D ultrasound or navigated ultrasound? Any questions?
Doesn't seem like it, Mark.
Okay, so maybe you close up then, Llewellyn.
Yeah. So thanks so much, firstly, to all our outstanding, really world-leading faculty for really what is a fantastic webinar. I think we were a little anxious about how it would go, but I think it's gone as well as we could hope for. And then again, thank you to our supporters, BK Medical, Sonoclear, University of Pretoria, and Europa Organization Africa. Then also all the attendees. There were, I think at some point we had a maximum of over 70, which is about a 70-odd% attendance. That's pretty good. And Claire and Google will keep you guys sort of updated about any other sort of further webinars that we have. So thanks everybody.